Hello, everyone. My name is Martina Anto-Ocrah, and today we are going to be talking about a framework for integrating emergency medicine with maternal health to reduce the burden of maternal mortality in sub-Saharan Africa. And simply put, this talk can be termed a woman's worth. And I'd like to thank the organizers of AFSAM 20 for inviting me to speak on this very important topic, which is near and dear to my heart. So to begin, I should probably give a little bit of an introduction of myself. I am a reproductive epidemiologist. I'm an epidemiologist, and I study most of my research actually takes a gender lens. So I try to look at whether it is injury outcomes, what are the sociocultural aspects that influence outcomes? Are there differences by gender? Do men have better outcomes than women? Do men have worse outcomes than women? Or do women even have better outcomes, right? And what are some of the predictors of some of these issues? Um, so this talk, actually, the authors are listed on here. So it's myself, as well as my colleagues, Dr. Jeremy Cushman, who is the Director of Emergency Medical Services at my institution, the University of Rochester, Dr. Michelle Sanders, who is a health services researcher, and Dr. Timothy Dye, who is an anthropologist. What motivated this work? And I love sharing this story because what motivated this work, I mean, I've always known that I really the gender was near and dear to my heart, but what really triggered this for me was this image, a newspaper from a newspaper in Uganda. And basically what it shows is we have a bicyclist who is the paramedic, if you will, transporting a pregnant woman, heavily pregnant woman in active labor to whatever medical facilities are nearby. And I would love to say that maybe this image appeared in the newspaper maybe a long time ago. I would love to say that appeared in the newspaper maybe like in 1990. I would love to say that appeared in the newspaper in early 2000s, but no, this actually appeared in the newspaper just last January. And the title of this image is, when will emergency medical services systems be improved? This triggered something in me. So it had me thinking, all right, what is the worth of a pregnant woman? Okay. The World Health Organization has identified key emergency care interventions for reaching maternal mortality benchmarks. And these key interventions actually call for timely access to emergency obstetric care. And apparently, once we're able to adopt these interventions, these emergency care interventions, and provide timely access to a laboring woman or pregnant women in general, it can actually avert up to 98% of maternal deaths across the African region. 98% of deaths. What does that mean? So let's take a country like Ghana, where I'm originally from. Let's say deaths are reduced by 98% in Ghana. That means that in 1990, when our maternal mortality ratio was 634 per 100,000, which equaled 3,600 deaths, if we're able to adopt these emergency care interventions, we actually will only have 72 deaths. So just think about that. In the year 2000, 10 years later, where we have 3,100 deaths, would actually only have 62 deaths if we reduced maternal mortality. If we adopt these emergency care interventions to reduce maternal mortality by 98%. In 2015, where we only have 22,800 deaths, we'd actually only have 56 deaths. This is astonishing. This got me thinking about access. What does access mean? We talk about access. I'll be able to access a taxi here. I'll be able to access my doctor. I'll be able to access my provider. We use this term so frivolously, but access is actually not as simple, right? Access is quite complicated, but access is not necessarily unattainable. So access actually incorporates 5 key concepts. The first is the approachability of the care delivery. So being able to access a healthcare service means that healthcare service is approachable. Acceptability. It means that the healthcare service is acceptable to you. It's acceptable to you, the target user. Whether or not the healthcare service is available and accommodating is also an important aspect of access. And whether or not the healthcare service is affordable is important. It's the reason why we choose between an Uber and a taxi, right? And whether or not the healthcare service is appropriate. So what delays access to care. In maternal health, there are three crucial delays that delay access, but it turns out that those delays actually are also quite present in emergency care. So the three delays are the delay in seeking care. Okay, so my decision on whether or not I'm going to seek care once there's the onset of acute illness or injury. Okay, the delay in reaching care. Once I decide I'm going to seek care at a healthcare facility, how do I get to that care? That's a second delay. The third delay is a delay in receiving appropriate care. So I arrive at the emergency center, I'm triaged appropriately. If resuscitation is needed, I'm given that. A diagnosis is needed, I am dispositioned from the hospital, and whatever happens, whether I'm discharged or I'm admitted, all of that is along this continuum of receiving appropriate care. If there's a delay in any of that, that would definitely affect my morbidity and my mortality. So as we're thinking about emergency care, think about this also about that laboring woman, right? At what point did she decide that at what point was it decided that she was going to seek care at a healthcare facility? At what point was she able to reach the care? We saw the image of her trying to reach the care with the bicycling pedalist, who's the EMS provider, if you will. And then once she gets to the hospital, if she makes it, what kind of care does she receive? Let's overlay all of this with access. And this is a framework that I developed. Okay. So we have the three delays. The phase one is the delay in seeking care. Phase two is the delay in reaching care. And phase three is the delay in receiving the appropriate care. The components of access actually, it turns out, overlay beautifully with each of these three delays. So, approachability, whether or not the access is approachable, actually falls under the seeking care component. Whether or not that care delivery is acceptable also falls under seeking care. My ability to reach the care depends on whether or not that care, the access component of availability and accommodation, and the affordability also determines whether or not I will reach the care. If I take an Uber or a taxi, which one is most affordable or is going to get me there faster? And then receiving care, appropriateness falls under this. Under here, also, all of these other healthcare outcomes, which I'm going to skim over for now because I really want to get to the emergency care components of both the three delays and the components. So, in the emergency care component of seeking care, we have the ability to perceive emergency care services. So, is the emergency care service trustworthy? And will it meet my expectations of my system beliefs, right? So we have ambulance services that are being developed. Do they conform with my health beliefs? Do I believe in ambulances? Do I believe that ambulance is going to give me the care that I need? Or do I think that ambulances are simply designed to carry dead people, right? They're simply used as hearse. If that is a core component of my belief, then I'm not going to seek care in an ambulance. And an ambulance is not an approachable form of service for me, nor is it acceptable. My ability to seek emergency care services is based on my ability to make that decision autonomously, right? When that woman was laboring, was she able to make the decision to go and seek services at a healthcare facility on her own, or was that decision made for her by her community, by her spouse? So who is making that decision? And that is really based on the norms, what we think. And this is why I study gender, because that depends. The woman's decision is dependent on the norms, the cultural norms, the social norms, the gender norms, right? Is a woman allowed to make those decisions autonomously in the context in which she lives? It also depends on personal and social values, okay? Then the ability to reach emergency care services is based on mobility. I love this one. I love this reaching the care because this talks about geographic barriers, right? The physical infrastructure, the infrastructure of the roads, right? We have a bicyclist who's pedaling in a field of plantains. Does that make sense? Right. So the type of transport, the type of social support, who's going to put together the funding so that we go from a bicycle to an SUV, which can get over that rough terrain? What is the season like? If it's rainy season, is that bicycle or that vehicle or that ambulance going to be able to traverse the rough terrain because the roads are so bad. Reaching care is a huge, that second delay is a huge component um, of survival, mortality, morbidity. The next component, which falls under region care, is the ability to pay for emergency care services. So, as we're developing these emergency care services, these ambulances, we need to consider the cost component because who always ends up not gaining from these interventions are the most vulnerable, the most at risk, our rural populations, right? The sickest of the sickest. So, we have to think about the social capital, health insurance, coverage. Who is going to benefit from this? And most importantly, who needs it the most. And then under receiving care, the appropriateness, the ability to engage emergency care services based on the fit between the needs. So whether there is a caregiver support, whether there is adherence on the side of the healthcare provider. So what measures can we have? How can we measure whether or not each of the three delays are basically fulfilling the components of access as well as the emergency care components? How do we measure that? We get to the very last orange box here. And I propose the way to measure that first, the seeking care is activation of EMS, right? Once we develop these emergency medical services, how often are they being used? Is it deemed approachable? Is it deemed acceptable enough for the utilization to begin, continue, increase, and to be sustained? Important outcome to evaluate. And then if that's not working, we go back to the drawing board and we figure out why the emergency care services is neither approachable nor acceptable to the target population. Reaching care, a metric that we can measure is the ambulance transport time, right? So how long is it taking for the ambulance to arrive on site? What is the on-scene time? What is the arrival time? These are important metrics to measure and to evaluate. If it's taking an hour for an ambulance to arrive when I activate EMS, that's potentially problematic because in that time span, I could have gotten an Uber, I could have gotten a taxi. So if ambulances are being perceived as being slow, they're definitely not going to be adopted, right? And then the receiving care components, I actually have proposed a two-pronged approach. We have out-of-hospital care being evaluated. So the care being provided by providers and other EMS providers, by paramedics and other EMS providers, as well as in-hospital triage and care by the emergency medicine providers in hospital. A measure is to do a correlation of the EM training programs and providers with in-hospital maternal mortality, right? So providers are being trained on certain skill sets. How is that playing out in the hospital setting? How is that playing out in the out-of-hospital setting? If they're learning CPR, is that playing out in the field? Is that also being, by playing out, I mean adopted? Is that being adopted in the field while they're on scene? So would the patient arrive intubated, right? Did the patient arrive with oxygen? All of those components, if they receive the training, is it actually being applied? So here's my question. Is a pregnant woman worth EMS activation in the seeking care, the first delay, right? Is a pregnant woman worth timely and efficient ambulance transportation systems so that she can reach the care? And is a pregnant woman worth appropriate in hospital and out of hospital care? These are questions that we should be thinking about. So when the three delays are presented, they're presented quite simplistically. So we think of it in somewhat of a linear fashion. We think of it as deciding to seek care in the phase, the first delay. The second delay, identifying and reaching medical facility. And a third delay, receiving the appropriate and the adequate and appropriate care, right? That's how we think of the three delays model. However, it is incredibly complicated. The woman's, as I alluded to before, the woman's decision may not be her own. So in the first phase, deciding to seek care is confounded by other socioeconomic or cultural factors, gender norms, societal expectations, perception of ambulances. This will influence the decision to seek care. The accessibility of the facilities also factors into the decision to seek care. Is it worth it for me to go to the hospital? Is it worth it for me to call EMS? Right. And also, How am I going to reach that medical facility? Those geographic barriers. Is it worth it for me to traverse this terrain to get there? Or will I be better just having a midwife at home help me out? The quality of the care influences the decision to seek care. If I know of someone else in my circle who has passed away from calling an ambulance, right? Am I going to call the ambulance as well? And maybe the person passed away because of the second delay. But all I know is when the ambulance was called, that person did not make it. That is going to influence my decision of whether or not I'm going to utilize the EMS services. So we're always thinking about a target user. Is the target user going to be able to adapt our EMS systems based on the cultural norms? Are they going to be able to adapt our EMS system based on the accessibility of the EMS? And also, are they going to be able to adapt the EMS systems based on the quality of care, the rumors that they have heard? That is why evaluating the training programs that are being taught with actually the application of them in the third delay is incredibly important. To end, we really must strive to make such images obsolete. It is astonishing to me that such an image appeared in a newspaper in 2019. But it also makes sense because here we are, we're just now beginning to develop emergency medical services and realize the importance of them in our healthcare systems. We should put the pregnant women or the women at the forefront of this, if possible. Because, yes, every patient is important, absolutely. But there is one patient who, for 9 months of their life, interacts with the healthcare system and also faces life or death. For 9 months out of 12 months, a pregnant woman faces life or death. And especially in the third trimester, those 3 months are incredibly critical. So everyone is important. Men are important. Women are important. Children are important. I'm not saying none of those individuals are, but the most critical patient, as we're thinking about vulnerable populations, is the patients who need these services the most. And for me, it's that pregnant woman during those 9 months when she is carrying the burden of taking care of herself as well as the onboard fetus. I'd like to pause now for questions and comments, but also mention that if you'd like to read more about what I have proposed, this paper has actually been published and it's open access in BMC Emergency Medicine. And the title is exactly the same as this talk, A Woman's Worth, an access framework for integrating emergency medicine with maternal health to reduce the burden of maternal mortality in sub-Saharan Africa. And I'd like to again thank the organizers of the AFSAM 2020 team for making this talk possible. So I'll now open it up for questions or comments that you may have.